Hi, everyone, and welcome to another exciting Wu University event. My name is Dr. Stephanie Wu, and I am the founder of Wu University, and I will be your host for this evening. And now it is my pleasure to introduce our speaker, Dr. Scott Hausworth. Dr. Hausworth graduated from the Southern California College of Optometry, and he completed a residency at the Minnesota Eye Associates. He is an expert at cornea, glaucoma, and refractive surgery, and that's what he was learning during his residency. He is now an assistant professor at the Department of Ophthalmology at the University of Colorado School of Medicine. He is also the director of the Ocular Surface Center. Scott is a good friend of mine. I had the pleasure of speaking with him years ago at Vision Expo. He's a wonderful colleague and an incredible, not only scientist, but clinician. And I think you guys are going to learn a ton from him. And thank you so much, Dr. Hausworth, for being here. I'm really excited to hear from you.
All right. Thanks, Stephanie. And thanks to Regenerized for sponsoring this as well. So today we're going to be talking about regenerative medicine and how to use some of the tools that we have in eye care. So what do we have at our disposal, and when do we select certain tools over others? So I do have a few disclosures, not really anything that's super relevant to what we're going to be talking about tonight, but I do cover basically both my clinical experience with some of these things, as well as we'll take a dive into the literature to explore, what other scientists have been able to find about what we're using, and then also a little bit about how they work too, because that's kind of important as well. So first off, what is regenerative medicine? So really, this is the concept of using biologic tissues and extracts to repair wounds and restore tissues and organs to their normal, healthy state. And the idea of this regenerative concept really actually goes back all the way to Greek philosophy. So Prometheus, which is the Titan god of fire, actually used clay to actually create humans. And so then that whole concept of creation actually goes back to him. So, but we have several different, concepts underneath this. We can use biomaterials, different types of engineering concepts. And then there's something called stem cell therapy, which we'll be taking a dive into as well. All right, so true stem cell therapy actually consists of utilizing cells and tissues that have these three following properties. So first, they have to be able to proliferate. They have to have the concept of self-renewal. And they also have to have the concept of clonality, meaning they arise from a single source. That's really what a stem cell is a single cell that can differentiate into others. And that kind of ties into the third concept of potency, which basically means that they can differentiate into different cell types. And the image that we're seeing here is actually kind of the true concept of stem cell therapy, where cells from the inner portion of the blastocyst basically can then differentiate into several different types of tissues. And most of these actually derive into mesodermal types of tissues, but also we can see also neurons, which are derived from the ectoderm. Those can be induced as well. So amongst different stem cells, there's actually a hierarchy, and we won't take a lot of time to explain this, but it's important to understand where these things come from and sort of what their potential is for differentiation and use. So the totipotent tends to be the most, or omnipotent tends to be the most flexible and can differentiate into many different types of cell lines, and those are derived from the earliest stages of fetal development. The pluripotent cell lines also can differentiate into multiple cell lines, and those are the ones that we see that are derived from the inner portion of the blastocyst, as I showed you on the previous diagram. The multipotent lines can differentiate into cells primarily from the same germ layer, and this is really when we think of mesodermal cell lines like bone, muscle, adipose tissue, etc. That's where these come from. Although recently, and it's thought that those could really only follow that one particular path, but recently they found that they can actually induce transdifferentiation of these particular cells from mesodermal into ectodermal tissue or neural tissue, as I mentioned in the last slide as well. The ones that we're probably most familiar with actually are the oligopotent cell lines, and this is really derived from adult tissue. So we think about, say, like the limbus, we have like limbal stem cell niche there. And those particular stem cells actually give rise to the epithelium of the cornea and contribute to that barrier up against the conjunctiva. So we have those kind of dispersed throughout our body in different areas for just regeneration of those normal organs and tissues. So when we think about how we use these things in ocular care, are we really using stem cell therapy? Well, kind of, but technically in most cases, we're really probably not using those true cell lines. A lot of those things really still are research oriented, but what we're trying to do is harness different aspects of that fetal environment, which is really very special, right? So one thing that makes this particularly attractive is in the fetal environment, there is again, regenerative healing process that goes on that limits the formation of scar tissue. It limits angiogenesis, and it really creates more of a natural physiologic state. And so we're trying to use different products to really support and heal sick tissues on the ocular surface. So that's really what we're getting at this point. But again, there's more things that are coming in the future. So how do these therapies really differ from traditional pharmaceutical or surgical interventions? And I think this is an important question, and it really helps differentiate the tools that we have in this space from the things that we can have patients pick up, like say from a pharmacy and whatnot. So pharmaceutical tools traditionally really focus on one particular aspect. So this may be, probably the easiest example of this is really inflammation. So we've had steroids for a long time. They've been around, for many, many decades. And those inhibit basically a large portion of the inflammatory cascade. And what's happened really in pharmaceutical development is to try to protect patient safety. We've really gone much, much more focused into particular aspects. In inflammation, we can see just in ocular surface disease, we can see calcineurin inhibitors such as cyclosporin, which really inhibit one particular portion of that cascade, which then upregulates cytokines and recruits T cells. And we can contrast that with, say, something like lifitegrast, which has a little different mechanism of action, although it still falls into that sort of anti-inflammatory or immunomodulatory category. Now, surgical interventions obviously can change the architecture of the tissues and change the mechanics of the tissues. And this can be really helpful at solving specific problems, but it always involves, at least outside of that fetal environment, it always involves adult healing processes, which lead to things like scarring, angiogenesis. And that's why we don't always get the perfect results every time we do surgery. So regenerative medicine actually really attempts to accent these tools to help restore a more natural physiology and a more natural anatomy for patients, because they incorporate different biological process to accent that wound healing and limit those processes. So what options do we have in eye care to use these tools? And we'll try to dig into these a little bit as well. So in the ophthalmic space, we have things like amniotic membrane, and these have been really probably pretty well taken up by optometry. We've got two different major classes here, the cryopreserved and dehydrated, and personally, I think they fall into slightly different categories because how we process some of these regenerative medicines can actually affect the biologic processes that come from that. So in addition to that, we have amniotic membrane extract drops. These are drops that are actually derived from some of the cellular materials, and they try to take supernatant liquids that will capture some of the growth factors and other powerful things from the amniotic membrane, and they can convert that into an eye drop too. We have amniotic fluid drops now, and you'll be hearing a little bit more about those from Regenerized, and we'll take a look at the science behind some of that as well. One other particular category that I think kind of helps or falls really into the regenerative therapies, although it's a little bit different, are the blood-related products. So we have autologous or homologous serum, which has been around actually for quite a long time. And then a couple other derivatives that really are differentiated. They're still blood products, but they're differentiated by how we process them and the extracts that we develop from them. And then you have things that are a little bit even harder to find, like umbilical cord serum drops, which can be difficult to source. So we'll take a look at the blood products first. So we have serum eye drops, and these can be primarily, we use them on an autologous fashion, meaning it comes from the donor and used on themselves. Then they have studied homologous use to see if we can take healthy individuals that may have blood plasma that's more rich in growth factors and other electrolytes and proteins, and transport those into patients that are sicker and may not have as much stuff in their system that can be useful. This has been around a long time. So the first use of serum in the cornea world really was as its use as a storage medium, really, for corneal grafts back in the 1960s. And it didn't take very long for them to see that, the benefits of this and the flexibility of serum could be used to help promote wound healing in different types of corneal disorders as well. And that started in the 1970s. And then it's progressed from there. We saw a long period of time where it really wasn't utilized very frequently in eye care, but really starting in the late 90s and early 00s, it's really picked up in popularity. And really, if we look at the amount of literature actually that's kind of gone along with this, just in the last 10 years now, we have about 260 articles in PubMed that have studied different aspects of autologous serum for ocular surface and corneal disease, where we had just a few hundred really from the 1960s to 2000. So it really has increased tremendously. Now, serum actually, the way I explain this to patients where I think it's beneficial is really, this is kind of like bypassing the glands, because the graph that I've got, or the image that I've got here on the right-hand side of the screen, really shows changes or differences really in the basal tear secretions for different proteins, immunoglobulins, and other things that are important for cell survival. Compared to what's in the serum. And so you can see there can be differences in many of these things. So we can see, like, say, vitamin C, the ocular surface is exposed to a lot of oxidative stress. And the concentration of vitamin C is much, much higher in the basal tear film than it is actually in serum. But then the opposite can be true for other compounds as well. And so for patients that have a really sick ocular surface, and along with that, we see usually a decrease in tear production. Or if you think of like Sjogren's patients or graft versus host, where their lacrimal system isn't functioning very well, a lot of the stuff really ultimately is derived from the serum anyway. So what we're using, or what we're doing when we use these products, is really kind of bypass the lacrimal gland and tear secretion systems and kind of put the stuff directly on the surface of the eye. So things like lactoferrin, lysozyme, and albumin are present in our blood supply too, and those are obviously very important for the ocular surface. So concentrations of serum, this is actually kind of an interesting topic, and I kind of put this in last minute because a lot of people will ask me after we talk about this, well, what kind of concentrations are you really using? And really, traditionally, if we look at the literature for ocular surface disease and cornea, the general concentration of serum is really about 20 to 25%. Most of them are probably actually 20%. And this is really based on the concept of a cytokine that's present in the tears, as well as the serum, called transforming growth factor beta. And this is thought to be pro-inflammatory, and it may impede wound healing when it's given in high concentrations. And the ratio of this is really about 1 to 5 serum to tears. And so they thought that 20%, actually, if we're using it on a sick ocular surface, that should be kind of the limit of what we use to try to help heal difficult corneas. So if we look in the literature, most of these studies use 20% or 25% at 4 times a day. And I think that the way that I use it, I kind of follow along with that thought line. And patients with extensive punctate epitheliopathy, especially like Sjogren's patients, I'll probably start them off at the 25% concentration, because that's what we do at the University of Colorado, because it makes sense, right? But more recently, some studies report really no change in healing rates with higher concentrations, even up to 100%. And this can be even in difficult patients here too. So Tamaz and Botella looked at graft versus host and how the ocular surface responded to 100% serum, and found that it didn't really change the rate of healing, and all patients really seemed to do pretty well with it. There were really no ill effects. Where I tend to use higher concentrations, and I don't use 100% very frequently, it's really more 50%. I tend to use those in corneal neuropathic pain patients or hyperesthesia patients where their sensitivity is actually quite high. I also use it in older individuals where we think that the level of growth factors and other things that are floating around in their system is probably decreased. Now, interestingly enough, last year, there was a publication by REPA in ocular surface that looked at concentrations of growth factors in patients that had systemic disease and compared it to healthy individuals from a serum standpoint. And they did find that there was a pretty significant difference in growth factor concentrations between those two individuals, which you'd expect, right? It also impacted the efficacy of serum in healing the ocular surface. And so I think that there's still a lot for us to learn in this area, but it does make us think that, perhaps we should be doing some sort of augmentation on our sicker patients because we might not be getting what we need to really out of the lower concentrations. So other blood products are things like platelet enriched plasma, which is blood derived, same as serum, but it's processed a little bit differently and handled a little bit differently than serum. And there have been a number of studies that looked at this in difficult cases. A good study just published 2 years ago, looking at 164 eyes with dry eye, showed significant improvements in OSCI, so symptom scores decreased, conjunctival and corneal staining decreased, and it even decreased osmolarity. We think that, again, this is helping restore cellular health. A lot of our surface cells on the cornea really derive a lot of what they need to do well from the tear film, and this accentuates that. Plasma rich in growth factors is also a blood-derived product, but again, it's processed a little bit differently than serum or PRP, using a slightly longer and slower centrifuge. And then it's heat activated. They actually heat it gently initially to activate some of the growth factors, but then because usually there's a little bit of fuzz of some of the white blood cells and leukocytes that are present there, and those can be uptake when they try to take off the supernate. They don't want that because that makes it sort of immunoactive. So they'll heat it to a higher degree to destroy those, and then filter it, freeze it. And in studies, we can see it's been effective. And again, difficult cases like graft versus host and Sjogren's syndrome. Again, I haven't used this in my setting just because everything that we do with blood products is under IRB approval, and it takes quite a bit of effort to get there. But these have been shown to be helpful. And if you've got a flexible lab, these are two other tools that you can use for sick ocular surface patients. So amniotic membrane is another type of regenerative medicine or regenerative product, and this is kind of getting a little closer to the kind of true regenerative stuff. And this has been around a really long time. Those of us that have been in eye care for 10 or 20 years, can remember when this really started to hit the scene just after 2010. It was first approved. Procare was actually first approved in 2007. But really, it's been used in different areas of medicine going back almost 100 years prior to that for skin grafts. And then starting in the 40s, to promote healing of conjunctival defects. Now, in the late 90s, we started to see a lot more research around its use in more advanced ocular surface disease like ocular cicatricial pemphigoid and Stevens-Johnson syndrome, as well as ocular burns and ocular surface reconstruction. But we've kind of seen an explosion really over the last 15 years of products that are available for us to use. And so these are readily available to use in our clinics now. So one of the things that amniotic membrane does is it helps promote epithelialization. So the basement membrane of the amniotic membrane is quite similar to the basement membrane in the cornea. They're composed of similar collagen subtypes. And this does a number of things that actually help to heal corneal wounds and corneal defects. So facilitates epithelial migration because it has, again, a similar substrate. This also does some cell signaling. It helps regulate that extracellular matrix deposition, which can get in the way of some of these migrating cells. It reinforces that basal cell adhesion, And it promotes epithelial cell progenitor differentiation. Again, this is the process by which some of those basal cells move into wing cell and superficial epithelial cell positions. And along with that, it helps prevent the natural degradation or cell death of apoptosis. So a number of different things that it does from an epithelialization standpoint. There also are a lot of biologics that are involved in the membrane. Again, this is that inner cell lining of the placenta, which is then supported by fluid, and then you have the fetus inside of it. So there's a lot of growth and a lot of activity there. And so the biologics here have anti-inflammatory, anti-scarring, anti-angiogenic, and anti-pain properties. So from an anti-inflammatory standpoint, we see downregulation of cell surface markers like CD80 and CD86, which typically are pro-inflammatory, as well as limiting some of the major histocompatibility complex class 2 antigens. We also see that downregulation of that transforming growth factor beta, which we know is pro-inflammatory, as well as a few other interleukins that are associated with increased inflammation. From an anti-scarring, this downregulates two other transforming growth factors, transforming growth factor 1 and 2, which can lead to activation of fibrosis and activation of some of the fibroblasts that basically create scar tissue. And so the fetal environment here, again, is very anti-inflammatory and anti-scarring. Other biologic components that are present in amniotic tissue are things like epidermal growth factor, hepatocyte growth factor, which we'll talk about in a minute, platelet-derived growth factor, and a bunch of other things that are really positive for maintaining good cellular health. We also see things like fibronectin, and one other component that's actually quite high in amniotic membrane is heavy chain hyaluronic acid and pentraxin 3. And this is a complex that has properties to basically induce cellular change and differentiation in early fetal development. So epidermal growth factor is one we're probably most familiar with, just because it's one of the primary biologics that really kind of dictates the differentiation of surface cells. And we see this being really important in corneal wound healing. So even when we look in models of like mouse models and cell culture lines, if we can grow those that are really resistant or actually use growth factor antagonists, we actually can prevent corneas from actually healing at all. So it is a very important molecule for healing things like superficial keratitis or a persistent epithelial defect. But this molecule is actually quite sensitive to processing, and actually they found significant decreases in viable epidermal growth factor the longer or the more the tissues had been exposed to heat or to radiation. So that's one of the things that kind of differentiates dehydrated versus cryopreserved, is that what we want ultimately really is minimally processed tissue or minimally processed biologics to get the most out of them. Although those things can still work from a tectonic standpoint, they tend to have a little bit less viability from a healing standpoint, at least on the EGF standpoint. And how this differentiates for some of the others, I just have a little graph here on hepatocyte growth factor, because this also has several different anti-inflammatory properties as well as neurotrophic properties, things that actually help nerves regrow and function a little bit better. And then it affects different inflammatory pathways as well, and apoptotic pathways. So just a little bit of oversight there. So as I mentioned, there are differences between dehydrated and cryopreserved tissues. This is just kind of a quick breakdown of how each one of these things is done. And of course, there's actually quite a lot of dehydrated companies out there right now, and they all probably have slightly differentiated methods of doing this. But gamma radiation and heat can actually help modify some of those proteins in a negative way, unfortunately. So we may see a little bit less of that for wound healing in dehydrated versus cryopreserved. So other functions, though, besides wound healing, we can actually utilize some of these tissues for drug delivery devices. Keep in mind that regenerative medicines, while they are probably one of the potentially one of the most helpful things, depending on the patients we're working with. They also can work alongside some of the traditional allopathic and pharmaceutical medicines that we have too. So one of the things that's been interesting is the concept of utilizing amniotic tissue as a drug delivery device. And this has been studied in a couple different things. First off, in utilizing topical voriconazole, which was soaked into amniotic membrane buttons and delivered. They studied this essentially over a 5-week period and found that the drug release was actually pretty consistent up to about 5 weeks with pretty minimal soaking time. This is up to about 3 hours. So that represents an opportunity for us to be able to help patients with infections as well. And this has been done also with moxifloxacin, which is something that we're probably all very familiar with. So the release kinetics in tissue here really, again, kind of modeled the voriconazole study as well, and out to 7 weeks. So if we're allowed to soak these buttons of tissue in antibiotic and then apply them to the ocular surface, we can actually do a good job of making sure that there is drug actually getting to the surface and not acting necessarily like a barrier. And this has to be done right now ahead of time, though, not alongside it. So how are these things gathered? How is amniotic tissue and other products gathered? So most of these fetal derived or placenta derived products really are kind of harvested at the time of cesarean section. That represents the least risk, obviously, to the fetus, to the mother. And it also allows for them to get some testing done as well to ensure safety for after it's processed and delivered to us to give to our patients. Blood serum, PRP, et cetera, those are all done via phlebotomy. And then can be processed either on site. I know several doctors that do this actually in their office. And here at the University of Colorado, we actually have the pharmacy that actually has the protocol to do all this stuff for us. So it's not something that we do personally. Now, it's important, though, that we are talking about biologic products, right? All of this stuff actually comes from the human body. So there can be varying concentrations of biologic properties depending on the time that it's harvested, depending on where it's harvested from, the thickness of the tissues, and then how sick or well the individual is. And so that's an important concept. So we may not get necessarily equal results between different individuals just based on where this stuff comes from. There's going to be some natural variability there. Okay, so for processing of amniotic membrane extract, this is another product that we can use. This varies quite highly right now. There's not really a good standardized process here yet. So getting it from one particular source, they may have a slightly different method. But this actually came from Ocular Surface a couple of years ago. And the process that they developed was to wash the amniotic membrane itself with a couple different antibiotics to make sure there wasn't bacterial contamination. It was basically cut up into small pieces, submerged in liquid nitrogen, and then it's homogenized, basically kind of just blended up, centrifuged, and then they collect the liquid off the top of it. And that's why it's called an extract. And then it's sterilized and filtered through a point or a 1/4 millimeter sieve. But other processes of obtaining extract actually involve pulverizing the tissue, microionizing it, morselizing it, and all of those different ways of processing it will affect how much good stuff we get out of it. And so these are not probably really commonly used in eye care right now, just because I don't think we've had a lot of companies that have stepped up and kind of filled this area. But it's going to be important as we look down the road to really understand how these are processed by whoever makes them available. So amniotic fluid also is harvested at the time of cesarean section. Now it's interesting here, and we talk about variability. There have been a few studies that look at like how much growth factors are present in amniotic fluid, how many proteins and organic salts are present that can work for us. And they found that from a proteomic standpoint anyway, there is a good window in and around the second trimester where things seem to be at their peak. And as we get a little closer to delivery, some of those things will actually drop. And that may be reflected a little bit in the fact that scarring is minimized the earlier we go in to the womb surgically too. So when they've done fetal surgeries, and the idea there is to see how the after the child is born, is there a scar there or not? When things are done, usually at the beginning of the second trimester, there seems to be a little bit less fibrosis and a little bit less, collagen activity in those areas. But when we look at stem cell portion of it, they also find that while the peak is at or around the beginning of the second trimester, they still have stem cells present even late into the pregnancy. And although there's a little bit fewer of them, these are still maintaining the property of being able to be differentiated into those pluripotent stem cells. So again, those carry a little higher hierarchy, and being able to differentiate into multiple cell lines. It's good that we have that even up to later in pregnancy. Now, when I was looking at amniotic fluid and its use in eye care, I mean, we've got obviously Regenerized, who again is kindly sponsored this program, and we'll talk a little bit about my experience with it here. There's actually a few things that are important in the literature for you to know. First off, the majority of it right now is water, but those mesenchymal stem cells and the extracts from those are really kind of what we want and what we're after to be able to promote wound healing. So we also see things like epidermal growth factor, insulin growth factor 1, VEGF, and a bunch of other things that are important for wound healing in amniotic fluid. However, when we look at what is available really in peer-reviewed published literature, we're still missing a lot of stuff. And so right now there's kind of a big gap, which I think really represents an opportunity for us that are utilizing products like Regenerized to really kind of take a hard look at our patients. And what this has actually inspired me to do is we've utilized it in about 48 to 50 patients, Dr. Gregory and myself, and we're actually going back and retrospectively and now analyzing how our patients are doing, because right now there's just not a lot in peer-reviewed literature looking at this particular product. Anecdotally, what I can tell you based on our preliminary review is that most of the patients seem like they have gotten either improvement in their symptoms, or we've been able to notice improvement in their signs. And we've thrown this at some tough cases. So things like lymphostem cell deficiency and difficult, persistent epithelial defects. Those patients have actually done pretty well with this, but we're not seeing a whole lot of support from the literature as of yet. So I think this is sort of a call to action for us to, again, optometry could potentially lead this if we decide to take a hard look at this and then maybe publish what our findings are to get some support. Where I've used this most frequently really is in dry eye in elderly and chronically sick individuals. And this kind of goes back to what I was talking about earlier, where patients that are in kind of not a great state health-wise probably have less growth factors circulating around in their system, and they probably don't get as much benefit from serum tears. And so we can use it as an adjunct to serum tears. I've used it there. I've had some patients that have reported good improvement that have neuropathic pain. And then also, and I'll share a case later on, in younger patients or patients that are unable to really obtain serum tears. So this fills kind of a nice gap, and it's a good adjunct in those cases as well. So how do we use all of these things? We know kind of what our sort of toolbox looks like now. How do we decide what to use, what, and when? And so I think for these cases, we really probably need to take a look at whether this is really an acute problem or a chronic problem. Is it a tectonic repair, or do we really need to have like an active wound healing? Do we need to have mechanical protection at the same time from either the environment or the lids or something of that nature? Do we have high levels of inflammation? Is it something that's going to work alongside pharmaceutical therapy? Is there a risk of scarring? And are there other anatomical barriers? For example, in patients that have cicatricial pemphigoid, many of them may not be able to accommodate something like a procarat, where they actually have the large PMMA ring. So we have to take a good look at our patients and kind of decide what type of problem it is and what they're able to accommodate. So I've kind of broken it down here too when we look at utilization, and this is really in particular the things that we've talked about so far. Just because in our clinic it takes about a week to get serum, I kind of view this as more of a longer term therapy, and it can be ongoing. So serum or really blood products, just because of the nature, we typically get about a 3-month supply of it. And I think if you don't have it available for you, you can use like Vital Tears, and you can get a 3-month supply from them too. It tends to be a little bit longer. Whereas when we look at something like amniotic membrane, that's actually much more acute conditions. The membrane itself may only last a day or two in really severely inflamed eyes. We can repeat it to maybe go out a little bit further than a week, but those are really kind of at the other end of the spectrum. And then we've got things like the amniotic fluid drops, which actually could probably span across the variety of things. You can get them fairly quickly, and the supply, depending on how you dose them, can last anywhere from a couple of weeks out to extended therapy. And so we have to kind of take a look at how we're going to utilize these and what sort of the projected course of disease is for these patients. So the things that we find, or I've found to be particularly receptive to these things, so things like infectious keratitis. So we do have to make sure that we're sterilizing the infection and utilizing antibiotic therapy, of course. But again, a big part of the problem with having an infection in the cornea is really development of potential scar tissue and loss of vision. So what we want to do here is potentially alter that healing process to help minimize scarring. And so this is where our regenerative therapies can be really helpful. In neurotrophic keratitis, here we're talking about either the absence or a significant decrease in nerve conduction. And we know it takes good nerve signaling to help to keep in a healthy epithelium. So that tends to be a little bit slower to heal as well. So that can be really helpful. Again, membrane and serum products contain amounts of nerve growth factors. So we know those things are effective in those conditions. Again, persistent epithelial defects, one thing that we see all the time really in dry eye. So a lot of these products actually can be used in dry eye therapy. And again, thinking about longer term, that kind of indicates what might be most beneficial to those folks. So, and then one other interesting area that we're learning a little bit more about is really the neuropathic conditions. And while we don't really have a good idea yet from an epidemiological standpoint how common this really is, because oftentimes it gets kind of dumped into the dry eye bucket, there are some studies that are ongoing now. I'm part of one of those multi-center studies looking at how frequently is this really a problem in dry eye patients in particular. And we found that regenerative therapies, things like serum and amniotic fluid, can be really helpful for those individuals as well. And there have been a couple of studies that have even shown that amniotic membrane can be helpful too. So lots of different cornerstones here. So we'll get into some case examples, and this is stuff that these aren't made up cases. These are patients that I've actually seen and what we've done with it. And some, for most of these, I've got at least a little bit of an epilogue. For some of them, we've got some pictures, so we can kind of go over how these are used. So the first case we'll be looking at is a 29-year-old male who came in after working with cement mortar, and the mix splashed up into his eye. And so he irrigated it, did the right thing, didn't seek treatment right away though, but noticed that his eye continued to get much more uncomfortable over the next 24 hours. He saw the ED doc who diagnosed him with a corneal abrasion secondary to chemical exposure, and then referred him to us after making sure his pH was at physiologic pH. So when he came in, we see his right eye is the one that was affected. It was significantly decreased vision. We can see a lot of erythema on the lid tissue, but most importantly, when we take a look at his cornea, his conjunctiva, he's got actually a fairly large epithelial defect, and it even extends out, and some of the areas of the limbus were affected here too. So we'll get into what his eye looked like initially, and you can see a little bit of that corneal haze here in the picture on the left, as well as the denuded area missing or absent of epithelium that goes out well past the limbus in that sector as well. So in a patient like this, really here we're looking at kind of acute management, right? So we double checked his pH just to make sure he was okay. Here we use something called the Procara Plus, which is a double thickness amniotic membrane. We protected him from infection with moxifloxacin, tried to control some of the inflammation with predacetate, put him on oral vitamin C to try to help limit that corneal haze. There have been a number of papers that have shown that as well, and then had him lubricate. And the reason I picked this case is it's kind of interesting. What we saw at a return a few days later is in the picture on the right, you can see these two little islands. Here, if you can see my cursor right there and right there. And this is actually coming in right at the limbus, right? So this is kind of regeneration of some of those limbal stem cells that we talked about before. And so we can see those starting to repopulate even in an area that was affected by a chemical just a few days earlier. So what we're able to do is take him out of the membrane here. We were able to pull back a little bit on his Pred Forte and his moxifloxacin, continue his vitamin C, and then had him follow up in another week. But I was feeling pretty good about it because we had some of that regeneration of those limbal areas. And what we found 11 days after his injury, he was back to 2025 from his initial visit of 2200. His conjunctival defect had basically closed. There was no blanching. His cornea looked great. And so we continued to heal. So did very well there. Now, the next case is kind of a tough one, but again, it shows how these things can be utilized even in tough cases. So this is a 37-year-old male that I've been taking care of for graft versus host for probably close to a year, and he presented relatively recently with really pretty incredible pain. It was worsening over 4 to 5 days, just over kind of a long weekend, and came in with a huge open epi defect in the left eye. He was on systemic immunosuppression. He had no infiltrate in the area, minimal conjunctival changes. So one of the things that we thought would be important here is just to make sure that we ruled out infection. So I cultured him. We put him on moxifloxacin to try to protect him against infection, watched the cultures really carefully, did have him start on a little bit of Pred Forte, but then again, put him in a membrane and had him increase actually his autologous serum. He was utilizing it 1 to 2 times a day before. We had him bump up to 4 times a day. After about 2 weeks, and again, this is an immunocompromised patient, he was up to about 50% improvement, grafted, or the open defected mostly closed. What we're thinking about doing for him the next time around is actually maybe grafting surgically a bit of amnion onto him with partial torsorrhaphy to kind of close up his eye a little bit more. And he was culture negative. But again, this kind of goes to show you that if one doesn't get it done in these tough cases, sometimes you need to use more than one therapy concurrently. Severe dry eye. So another patient that's about 84 years old, longstanding Sjogren's disease, rheumatoid arthritis. She has some GI inflammatory issues as well. She's on a long history of medications systemically and has been on serum tears, steroids, and of course is on systemic immunomodulation. So in her eyes, we added regenerized to her, and in about 6-week follow-up, she was about 50% better and feeling much, much better. I don't have a follow-up picture of her. This was a short case, but again, you can utilize some of these therapies concurrently. Particularly tough patients can be neuropathic pain patients. So one in particular that kind of struck a chord with me was a lady that I saw probably about 6 months ago, and she came in for just horrible pain. She had had LASIK surgery about 10 years ago, and for years and years she was just told she had dry eye, and there's nothing more that they can do. She had tried just about everything under the sun. And she was really to the point where she's like, if I can't fix this, I don't know what I'm going to do. And unfortunately, a couple of years ago, you guys probably remember that story of the news anchor from somewhere out east that did commit suicide after developing neuropathic pain. So these are serious issues. So she had tried serum tears for about a year at 25%. She tried Restasis, Hydra, non-preserved artificial tears, pretty much everything either seemed to make it worse, aggravated her, or she got no improvement from it. So it was obviously really frustrating. So what we decided to do, actually, here's a little bit of her exam findings. So she had a pretty prominent incomplete blink, which I thought was aggravating some of her issues because that provides kind of a continual stimulus to the ocular surface. She had a little bit of a decreased tear breakup time. Here in Colorado, we see probably 7 is probably average. And I'm sure, Stephanie, where you're at, it's probably shorter than 10 seconds as well. Her lipid view was good. She had actually good looking meibomian glands. And other than the LASIK flap, there really wasn't any corneal staining or conjunctival staining to speak of. But, so we are really thinking, pretty strongly pointing towards a neuropathic issue with an incomplete blink, which exacerbates the problem. So we started her on 50% serum. Again, this is what I typically use for neuropathic patients. We had her use TRPM8 stimulant, which is essentially something like either Roto or Simulacin, which actually has kind of a cold trigger to it. The patients feel a little bit of a cooling sensation when it goes into their eye. We had her start on alpha lipoic acid, which is good for nerve support, and then also instructed her to do conscious blinking. So as often as she can remember to do it, just have her close her eyes once or twice, nice and slow, to make sure she gets full closure. And after 3 months, she had noticed 90% improvement in her right eye and 50% improvement in the left eye, which is the most she'd had in 10 years. She was extremely happy with us, and she continued to improve. Just saw her recently, and she's extremely happy with the results. And the last case I'll share with you actually is my own daughter. So this is she actually went through some cancer when she was an infant. She's 9 years old now. She had a history of CNV retinitis, which basically makes her monocular. And in her good eye, she started developing what you see on the right-hand side. So a little infiltrate there. You can see some vascularization. You can see the epithelium breaking down. And it was non-painful. She had no complaints of pain, but she just kind of felt, a little funny, and sun was bothering her a little bit differently. And she noticed that her vision was getting blurry. So this is what caused us to take a really close look at her. And this is what we found. So a patient that's like basically neurotrophic, but then has obvious signs of inflammation, what do you do? So, part of it is we try to address the inflammation and, limit chance for infection through traditional means. Because of her history with CMV and not really sure if when she was immunocompromised, if she had developed some issues with maybe herpetic stuff, we started her on oral acyclovir as well. But I thought, well, this would be a good case for us to at least try something like regenerized, which could maybe help kind of heal up that ocular surface. And since she's kind of below the age where we're kind of outside the IRB, we could do maternal serum. So I could, myself or my wife could do donate serum and then have it be dispensed to her that way. But that's kind of a hassle here. So Regenerized seemed like a good option, and actually it worked pretty good. So at 2 months, her epithelial defect closed. We had decreased haze, and she was back down to 20/25. So wish I had a picture over there. I should have put up one of her actually smiling here, I suppose. But that's the cases I wanted to share with you. And so in summary, regenerative therapies are super useful and can be used either as standalone treatments or adjuncts to some of the traditional pharmaceutical and allopathic therapies that we have. Certainly, they provide an interesting means to improve or restore normal ocular surface physiology. And the cool thing, I think, as I mentioned during the talk on amniotic fluid drops, is I think that really when we see a gap in the literature, this is something that I want to immediately fill. So, it takes some organization, it takes some planning, learn to work with institutional review boards and those sorts of things. But if anyone needed any help with advice on that sort of stuff, I can certainly work with you on those things. I do a lot of consulting and research as well. But we can fill that gap as optometrists. This is stuff that's well within our scope to be able to utilize. So in addition, don't wait for those really advanced cases. We can use these even in more common things too, like dry eye or even alongside, minor infections, just to help promote healing. So don't wait and regenerate. And that was kind of the impetus for the title of our talk tonight. So with that, just a few other thanks to some of my mentors and colleagues here at the University of Colorado and beyond. Thank you, Stephanie. And with that, we'll take some questions.
That was so great. I loved all of the case reports, and you have obviously some really interesting patients that you see and that you have seen over your career because of the type of clinics that you've been at. And I guess you must not have the issue that most doctors have when it comes to managing their own families. You manage your daughter super well and way above average, and I feel like I would have probably panicked. I don't have kids, but if I did, I feel like I would be like, I don't know what this is. How do I treat this?
Well, I'll be perfectly honest with you. I did have to take my hands off the wheel for a little bit, and fortunately, I work with some really talented cornea specialists that I trust. But when they're kind of shaking their heads and they're like, "Well, here's what I think, but what do you think?" there's a nice kind of level of sort of mutual respect, but I know kind of when to sort of take a step back as well. It's pretty tough. You do get emotionally involved, certainly. So
Definitely with a really special case like that.